trusted voice in health and science.
Thank you, viewers, and thank you everyone for joining us today. This is our first podcast that we are actually having here on HealthTimes TV. And joining us today is none other than Miss Lucy Marowa, the Chief Executive Officer for the National Blood Service of Zimbabwe. So maybe, without taking much of your time, Miss Marowa, could you just tell us who Miss Lucy Marowa is and what is your role as the Chief Executive Officer for the National Blood Service of Zimbabwe?
Thank you very much, HealthTimes. Thank you, Mike, for this opportunity. And I'm honored to be your first guest on the first ever podcast by the HealthTimes. So when you're looking at Lucy Marowa, she's a medical laboratory scientist by training, groomed by the University of Zimbabwe. And then beyond being a medical lab scientist, she is also an administrator with a Master's in Business Administration, postgraduate certificate in business leadership. She's also a doctoral student of strategic management with Shimoyo University. So I'm passionate about what I do. And as I lead National Blood Service Zimbabwe as the Chief Executive Officer, my role really is to make sure that the National Blood Program runs efficiently and that our National Blood Bank is kept stocked up. Not only that, it's also to make sure that everything that is to do with the value chain of the blood delivery program runs seamlessly. To try and keep everything intact takes a lot of work, and that means looking at every facet that goes into the delivery system of a safe unit of blood, be it the human resources, the financials, the testing systems, every process element, it is under my purview. But of course, it works as a system made up of many different parts.
Great. So maybe let's just dive really into it. Maybe looking at your operations, why do you think regular blood donation is critical for the blood bank?
Well, with regular blood donation, we are talking about people that come in to give blood more than once in their lifetimes. And in fact, not talk about a lifetime, but I'm saying a person who gives blood more than once in a year. So we want a repeat blood donor who comes in on a consistent basis. The beautiful thing about a regular blood donation is that the more you donate, the safer you are. When you look at the whole process of blood donation, it operates according to what we call a risk model, whereby we are able to use algorithms to predict the safety of the blood supply based on who you are, how old you are, the lifestyle you lead, how many times you donate. All of these elements, when you put them in a mathematical model, we can tell the risk profile. So you find that with the regular blood donors, because of how often they come to donate blood, each unit is safer than the last time because there's always that interval. There's kind of a regularity in the way they come in. So all of that really enhances the natural blood supply. But let me be quick to say that no matter how regular you are, we don't stop testing. Every unit that comes through our blood bank, we have to test it. But you will find that theoretically, should we ever require to issue out untested blood, I would rather receive blood from a regular donor than get blood from a first-time donor or from a not-so-consistent donor. But it never happens. I need to add that it never happens. We test each and every unit.
Maybe still on that, why do you think it's like that? Is it an issue of safety?
Yes, it's always an issue of safety because you find, like I did say, because we're using mathematical model to predict disease trends and so forth. Let me take you, for example, through the infections that we are talking about, whether it's HIV or hepatitis or so. You know, these diseases have what we call a window period between the time you get infected and the time that we are able to pick the infection from your blood. Supposing you get infected today with virus X, and it has a window period of, for example, 90 days. If you give blood today and we test it tomorrow, we might not pick it because you're in the window period. But if you come back after 90 days, we're able to pick that infection because you had 90 days from the previous donation. But then, if you are a person who is not a regular blood donor, you give a unit today, and then you go for a whole year, and then you come back. It means that maybe the first time you gave a unit, we found it is in the window period risk, and we probably missed the infection. And we are only picking you next year, and we missed out on that initial unit. Yet, when you came in, if you had come in more regularly, we would have picked you much earlier and be able to do the necessary intervention, which meant probably referring you for counseling or treatment or any other intervention. Because it's not every infection whereby we are saying that we want to exclude you as a donor, for example. That's what I'm just saying. We pick you and we're able to give the necessary intervention. You need to go for treatment, that's all right. If you have deferred from donating for good, that is also all right. So these are the things that we are talking about. Any unit that we pick as positive and we cannot transfuse is a cost to us, because those costs we have taken in to taste, we cannot recover them back. Indeed, this is an unusable unit of blood. But a regular donor means that they more or less have their blood always tested more regularly than the person who is coming in every now and then. That's where I'm coming from. Besides, also from a lifestyle perspective, a person who knows they're going to donate blood very often, they're a bit more careful with their life because they want to come back. But that one who goes and go away for 5 years, anything can happen in 5 years. I'm sure you agree with me. Yeah. So it's really like that.
So you also briefly touched on the issue of costs. Maybe could you just take us through what are some of the factors that influence the cost of blood, like when it is out there, like at the receiver side?
One blood being received really costs you thousands of dollars, and you can buy so many. So these are the cumulative costs that I'm talking about. It's an intricate business. And all I can say is that you need to see it in order for you to understand it. And when people have not walked through our walls, our corridors, they have no idea what they're talking about.
Still on cost, people say blood is expensive. What do you think about that?
Try to realize that blood is not expensive. What am I saying? It's relative. It's relative, I'm going to say that. Yes, you are paying in order to receive a unit of blood, but what you're paying for is not the milliliters that are inside that package. You're paying for that value chain that I've just described you there. That ensures that when we give you that blood, it's not going to kill your relative. Because if we don't do that, your relative might end up losing their life because somebody made a mistake somewhere, and that will cost your relative. When you also look relative to the earning levels of our country, again, it can be steep to a lot of people to pay the user fee for blood. But then you also ask yourself, but there is a free blood initiative when you go to the government hospitals. Yes. Since 2018, the government of Zimbabwe has been paying National Blood Service directly and saying supply blood for free in our government hospital, which, by the way, as National Blood Service, we've been doing religiously.
Then we also continuously get reports of blood shortages, blood stocks depleting, especially blood group O. Why is it always that we always have a shortage of blood group O?
We do, in fact, and it's a very painful issue for us. There are many reasons why blood stocks do run out, which we do not like, and we are working hard to try and address. The most notable one is that we get what we call seasonal blood shortages, particularly end of December, early January. This is really for a very simple reason. Our national blood program is skewed in such that greater than 70% of our collections are coming from the school-going age. An unfortunate development is that during the third term of the school calendar, most of the school-going age are writing examinations. They're in Form 4, they're in Form 6. You donate blood from the age of 16, if you do remember. At 16, you're in Form 4. So third term, when you're writing exams, we don't want you to donate blood because we're saying we don't want to disturb you. When you're in your A level, you don't want to disturb you. That leaves the Form 5s mainly, and a few Form 3s that are 16-year-olds, but you can count them. Our children are going to school very early. By Form 3, they are not 16. So that leaves you with only the Form 5s mainly. So when we go into the schools, our collections are very low. So we cannot stock up enough for the holiday season. And then once the children have gone back to their different hometowns, it's difficult to bring them all together again. So we then find it difficult to stock up for the festive period. That's the first one. Then when they open schools in January, the Form 4, the Form 3s, who were Form 3 the previous year are now Form 4. They're still to turn 16 again. That dynamic is still there. Those that were Form 4 have not yet started Form 5. So they are at home. That leaves you with those who in Form 5 are in Form 6, but they already donated last term. They are not eligible to donate. See how skewed it becomes. So that's where the gap comes in. So we struggle during the first term of the year. That's always the issue. But we are trying by all means to now find a way of harnessing blood donations from school leavers within their areas of residence by checking their home addresses so that we can follow where they are and organize blood drives from there. That's the first one. I will move to the issue of blood group O. Why do we run out of blood group O so much? Because 52% of the population is blood group O. When you walk into any institution, even any hospital, the majority of patients are blood group O. So if I move into a crowd of 100 people and I collect blood, chances are that 52% or 52 of those units are blood group O. So if I get 52 out of 100 blood group O's, I celebrate. If I move into a hospital where I have 100 patients, chances are that 52 of them are blood group O. But here is the issue. One patient requires 3 units, another one requires 4 units, but I only collected 52 from 100. But I also have 100 patients where 52 of them are O, but each one needs more than 1 unit from 52. So you see the maths, it won't click. So I need more donors to service less patients because one patient will require donations from 3-4 different donors in order to meet their blood needs. When a patient is sick, sometimes they will be transfused with 3 units, 4 units, 5 units, and they come from 4, 5, 6 donors as they need. Whereas one person can only donate 1 unit, which goes to the patient. So that's where the issue comes in.
The general belief is that when people donate blood, at the receiving side, it's only blood that is received, but there are a number of blood and blood products. Could you just take us through that?
We see the blood, the red blood that we see, because that is what is common, especially when we do our public campaigns, when we go to the schools and so forth. That is called whole blood that we are collecting. When we bring it back at National Blood Service, we are splitting it into a number of components. We have what we call centrifuges, which are machines that spin the blood, it separates. We have a clear fluid, which is straw or pale colored, what we call plasma. That's one is also used for patient use, and the red cells can also be used. That's 2 components. That same clear liquid can also be separated further. You get what we call platelets, and then again the plasma. So that becomes 3 units. That's 3 products from 1 donation. You also have people who can come in and donate other components through a process called apheresis. When we hook them up to a machine, the machine takes out the blood from the vein, it spins the blood, separates it into the components, it returns the red cells back into the vein, and the plasma and the platelets are what we harvest from the patient in real time.
You have this technology here?
Oh yes, we do.
Okay.
We have that actually.
Now let's jump into the technology question.
Yes.
What tech innovations does NBSZ use to ensure safety of blood and just throughout the processes here?
Okay, so we've tried by all means to make sure that we have automated quite a number of our processes, starting from the blood processing and separation itself. Whereas previously we would do it manually, you centrifuge, you then put it up, and then you squeeze manually, you separate, you tie. We've automated all of that. You centrifuge, you put it on the machine, it separates, it seals off, it ties off, and everything sealed in what we call a closed system. No contamination there. That's part of the technology we've put in place. Number 2, the testing itself. Whilst we have the proper serology testing that we are using from 2 different manufacturers, which I will not go into, we have now implemented what we call nucleic acid testing, which is state of the art, the best, the gold standard, where we can say that we will look for the presence of DNA or RNA, which is the genetic material from the virus itself. You cannot find genetic material where somebody has not passed through. Remember, DNA or what we call genetic material is like your imprint. So the moment you can pick up the genetic material of a certain virus, you know that virus is here. So that one is enhanced safety because it tells us infection is here. And normally it closes that window period I talked about because you can pick it up within days of the infection having happened. Whereas serology picks up your antibodies to say your body is now fighting infection, which can take much longer time than the nucleic acid testing. That's part of the technology we have put in place. We have also put in place what we call our blood bank system software, which helps us to put all these things together, such that, Mike, if you've donated in high school, if you give me your name and your ID number, I will tell you first donated at such and such a school on such and such a date, and I can check all your donations. This we implemented from about 1997. We've transferred all the information with every subsequent database, no matter how many times we change systems. We have all our records of our donors. So we are able to track, even if you go and donate in Bulawayo, we'll be able to tell, you donated yesterday in Harare, you can donate.
So there are myths and misconceptions around blood donations in Zimbabwe. Some emanate from religion, maybe others are also cultural. Maybe can you just share some of the myths and misconceptions that you have encountered in your line of work?
Particularly, I like to start with this one. They think that when you donate blood, when you get home, things are not okay between you and the madam at home.
Okay.
No, there is no such thing.
Yeah.
It doesn't affect that side at all. So please donate blood. You are still a man. And women, you will still be women. Nothing changes on that side. It's nothing but a myth.
Yeah.
Other people also think that when you donate blood, the blood portion of it might be taken and dedicated to some rituals at National Blood Service. Let me tell you something. We come from different faiths here. Some are Pentecostal, others are Catholic, others are Adventist, others are whatever. There is no way we have one harmonious faith where we can say let's do rituals at this organization. We couldn't care less. And others believe it takes up too much time. You go there for 3-4 hours. Blood donation, 15-20 minutes from start to finish, you should be done. Unless if you're going for the apheresis, which I talked about, where you're hooked to the machine. That one is a long, lengthy process, and it's not for every donor.
Now, so what strategies do you have to reach volunteer blood donors or other communities that you believe maybe you could actually get new blood donors from there? You indicated that you are now following up school leavers.
Yes.
Then now we're moving to maybe in terms of recruiting new blood donors. What strategies do you have in place?
We now want to promote adults. You know, a lot of people will tell you they used to donate blood. When I was school, you were one of them. You actually told me you donated blood once. You know, so we are now following up on such people and saying, why? Why did you donate once? What made you stop? So that we understand. And a lot of times we are realizing that it's because people grew older and busy, not because they don't want to donate blood. But we are realizing when you get to where they are, they're actually very willing. So we're now following up on adults. So we want to change the narrative from 70% youth, 30% adults, hopefully to get to a point of 50-50. And this could maybe address our challenges of the seasonal shortages that we talked about. So these are some of the challenges we're talking about. Use of influencers as well. We've realized that influencers are a big deal in this country. And we have very good partnerships with quite a number of influencers. If you check social media, quite a lot of them really support the blood program and they've done amazing work. And shout outs to them for standing with us.
What would it take for one to be an influencer for the NBSZ?
Just the passion.
The passion.
Just the passion and really believing in the cause. You really have to. Because we don't want people that are coming in because they want to make the money
That's true.
out of National Blood Service Zimbabwe. But we're saying believe in the cause so that when people then ask you questions, you can really articulate. More so, if you are an influencer and you can actually donate blood and people can watch you do it, I think people believe more what they see and what you live than what you say.
Yeah.
So for us, that's what we're looking for.
Good. Maybe as you're parting short, what message would you have for our viewers out there, and what message would you have for them that maybe would likely encourage them to be first-time donors, I would say?
Donating blood is a very simple, safe process. It's scary before you try, but once you do, you realize how fulfilling it can be. Just today, we celebrated a man who gave blood 300 times in his life, believe it or not. Imagine if someone can do it 300 times. What stops you from doing it once, twice, 10, 15, 20 times? It's doable. And yes, you will be in the best possible hands. Should there be any issues that you're unclear about, we are there to make sure we share notes, we explain, and we hold each other's hand. And besides, blood donors, we owe you our lives. No one has ever thanked you before. Here's me today saying, thank you for the countless lives you have saved in Zimbabwe. You are doing an amazing job.
Thank you so much, Ms. Marowa, for your time.
You're welcome.
It's been a pleasure.
Thank you very much.
Thank you.
HealthTimes TV, your trusted voice.